Dear friends in Ukraine, thank you so much for inviting me to be part of your meeting. It's a big honor for me. And I'm very grateful to be able to share one of my favorite topics, and that is about communication and checklist. And the question is it the same for aviation and anesthesiology? My disclosure of interests is that I have been the past president of the World Federation, the secretary of the ESAIC, the president of the European Board of Anaesthesiology. Currently, I'm a member of the board of directors of the Patient Safety Movement Foundation, and I am an anesthesiologist in Bærum Hospital in Norway. And relevant to this talk is that I have some flight safety experience. And where does this come from? Actually, this is now back in '86, a long time ago, when I was the first female medical doctor to serve in the military. The reason why I did was I was asked to be in South Lebanon during the war there, and I was brought by flights, and I noticed there when I was sitting in the cockpit that the captain and the first officer, they did not follow the checklist properly, which really made me quite scared. Even as you can see, I'm smiling on those photos. Later on, after my service in Lebanon, I did anesthesiology training, and I am a helicopter and flight doctor for a while. And during that period, we had to work with a flight crew in CRM, crew resourcement or cockpit resource management, dealing with how aviation is dealing with checklist communication in accident prevention. And that somehow was interesting also when I was in anesthesiology. And I can say that in Norway, those who have been in the air ambulance services have been at the forefront of advocating for checklists and communication training. And why? Well, this is an example from the cockpit in a helicopter. And a big important role there is communication, cooperation, and leadership. How the first officer, or here the rescue man, is supporting the captain in doing his job. And from aviation experience, what we learned through that training, which we had to undergo, is that in a situation in the cockpit, the captain would think that the communication is relevant and to the point, while the first officer would say diffuse. The same excellent task delegation and coordination, but the first officer unsatisfactory. Captain, situation awareness excellent, first officer unsatisfactory, and the same with the cockpit atmosphere, relaxed but effective. How come that they experience this in such a different way? We see the same in the operating theater. Here you can see what from British Medical Journal. It's an old article, but it's the same situation, how the surgeons found that this is excellent cooperation. And the worst was from the trainees in anesthesia. And big difference between the surgeons and the anesthesiologists. And how come? Well, according to survey in Norway, is that documentation, we know how to do that. We know how to prioritize. We know the things we are supposed to do, but leadership and communication are the big problems. And this is very obvious in the trauma room, where we have started simulation training all over the country, and just to train on communication and leadership in the trauma room. It has changed everything in how we do it. And we have so many small hospitals with a very little load of traumas. So you need to exercise in order to deal with the patients in a right way. The same is illustrated here in the Formula 1, when at the pit stop, they can change the tires in just seconds. And why? Because every one of these men or women know exactly what to do. And that's why the cooperation and the action goes so fast. The same is when we are playing games for children. We need to play by some rules, and everybody has to respect those rules in order for the play to go well. And this is again from my CRM training, the communication, because what is in my head, the sender, I'm sending the message. But then what goes out from my head and brain will be different when it comes to the listener. That's why it's important that the listener feed back to the sender, so the sender understands. And we see that in our normal relationships. Sometimes when we say something, it is interpreted in a completely different way by the listener. And we have different styles of communication, as illustrated in this joke, so to say, how it's much more complicated for some people and less for others. This is also an example from the rescue helicopter services, where the captain is a very young and not so experienced lady. And the rescue man and the doctor and the other staff, they are all done very experienced. How can they manage to work together? Yes, because the other crew members know that they have to play this captain good. They have to support the team leader in order to have a functioning team. And I'll give you some examples. There is a way in the air aviation industry that they know, and that is opening jack, and then a specific concern. I'm very concerned, just giving your own emotion. I am very concerned. And what is the problem? We are approaching 500 feet and are not established in a stabilized approach. Then if you have a solution, recommend we execute a go-around, request for feedback. Do you agree? And just an example from the trauma room again, we could say if a very unstable patient, bleeding patient is coming into the emergency room and the surgeons wants to take him to CT, we can say, oh, surgeon, you are just stupid all the time. We are going to kill the patient. Or you can do it in a different way. I am worried of this patient because the blood pressure does not improve in spite of the 4 liters infusion, and there is no blood coming from the 2 chest drains. I think the patient bleeds in the abdomen. That's the solution, even though the first ultrasound did not show much intra-abdominal fluid. Do you not agree that it's better to take the patient to the operating theater for emergency laparotomy? Then you help the surgeon to find the right solution without creating any stuff. Simple things we can do. In order to have effective communication, we should use name or roles. For instance, if we don't know each other roles, we can say, you surgeon, you operating nurse, or whatever. If you know the name, okay. Be direct and polite, tell what you think, but do not shout or anything. Loud and clear, as I said, not shout or cry. And then receive the closed loop, receive the messages. Can you collect 4 units of blood? You have not given that message until you have got it back. Yes, I am collecting 4 units of blood. There are some barriers of communication. For instance, if you are incompetent clinically, that will dominate all you do. Anger, frustration, emotional reactions, there can be many reasons. You could have been fought with your spouse. You can have some worries in a different way. You can have the focus on procedures and tunnel vision. For instance, we can be very focused on putting in that arterial line. We don't notice that the patient stops breathing because we are so focused on getting that arterial line in the same place. There can be noise and interruption, which takes away your focus, or you can do the wrong priorities or be too stubborn. There are various attitudes. You have those anti-authority. Don't tell me what I should do. Well, follow the rules. They are normally right. Do something quick, impulsive. Think first. Invulnerable. It doesn't happen to me. It happens to anyone. I will show them. It's stupid to take chance. Plan. Or it doesn't matter what I'm saying. I can contribute. This is what we should think about. And we have also in aviation a concept called increased assertiveness. And this can also be used in anesthesia. Draw the error to the captain's attention. I see there is high ground over this way. And if the captain remarks, you could say it in a non-confrontational language. I am concerned that this direction will take us close to the mountains. And if he ignores again, you should give him the solution. Let's turn right and move forward to lower ground. And still, if the captain still ignores, you should ask why. Could you please explain why you are not concerned about the high ground? And if he still ignores it, you should say, Captain, you must listen. We are dangerously close to the mountains. We must climb now. And at that point, probably the captain would lose his job anyway. But this sentence, Captain, you must listen, that's in aviation a sign that the captain must listen. So what is happening? Well, being a normal human being, we have those automatic thought processes. We have things that go automatically. For instance, when we have learned to drive a car, we do all the things, shifting gears for those of us who still use manual gears. We turn the wheel, we do all these things automatically. That is when the patterns have been set in our minds. In the beginning, we have to think, okay, clutch in, change the gear, steer the steering wheel. And that is very demanding and takes a lot of energy. But by experience comes those automatic thought processes. When we have the reason-based problem solving, that we have to think, okay, in with the clutch, shift the gear and so, we can have the wrong focus and ignore other processes. And one example, if we are trying to intubate, and we are doing this with a very concentrated, we can lose the goal that it's not the intubation, but the oxygenation, which is the goal. The same is confirmation bias, that we only acknowledge the confirmative information, so we don't see what is not fitting to the plan we have made in our heads. And we are looking for known schemes. Reality, we adjust it to things we have seen earlier. This is normal human being. And we see what we have seen before. As I said, we have only, and we see only that. These are just illustrations that we are vulnerable with to be a normal human being. So it's effective, but we get tired when we use too much of the concentration, and it leads to errors. And that's why we should have some help, some aid in what we are doing. But when we are dealing with problems, we should check the autopilot. Are we now on the autopilot? Is the map similar to the terrain? Stop, reassess, and follow the rules because they are normally right. And then I turn over to the checklist part of my talk. Because checklists have been, this is back from 1920, the first checklist we know in aviation. And today it sounds a little bit strange, but it's do not trust any altitude instrument. No plane is to taxi faster than a man can walk. But otherwise, the concept is similar to we do now. And this is from B-32, from World War II. When you have this normal checklist, when you enter the plane, you should check this and that before starting engines, and warm up. The concept is the same as it is in the normal checklist today. Now, as I mentioned in the beginning, not all, when I talked about my own experiences, not all pilots follow that, which they should do. And they have to help, have to help each other remember it. So this is what I just mentioned. And the way they do it is that you read it, and then you do what you have said, start the engine, then you start the engine, and then you say engine started. And that's what you do through the whole checklist process. And this is the same with the surgical safety checklist, which has now become generally accepted in our field. We ask, we check, and we report back. And then it's interesting when the surgical checklist was established, then we think that, well, the checklist would remind us about what we have forgotten, so we will do it. But they realized that there would be other effects as well, like less bleeding, less anastomosis leaks. Why? Those are not in a checklist. Could it be that there are less distractions, or are indirect effects more important than the content? For instance, it has been shown in the beginning of the surgical checklist that just that you introduce yourself in the beginning of the team, it makes you less worried to speak up if you see something wrong later in the process. So you get more confident of speaking up. So that's also what the World Health Organization and WFSA, International Standards for Safe Practice of Anesthesia, have highly recommended to do the surgical safety checklist. And it's the same in the Helsinki Declaration on Patient Safety in Anesthesiology. It should support the checklist. In the trauma room, as I mentioned earlier, there is also a checklist about following A, B, C, D, and E, as you can see here. And what we have found is that this also serves as a reminder, because a person who is reporting this or writing all of these figures down will remind, if they have forgotten to do a urinary catheter, she will or he will ask, what about urinary catheter? Oh, I've forgotten, I put that in. So it's also a tool for reminding. So when we have seen that the checklist is so useful, then it's very simple to think, okay, we have to do checklists for everything. And this is what has happened. Doctor inspired a pilot's safety check. And you can end up having checklists for this and that. Well, you have to be careful, because you can end up in a checklist chaos. And that's not what you want. So you have to be very, very careful what you do. Then you have another type of checklist, and that's the emergency and the abnormal checklist, which act as a memory guide in serious actions, ensure that all critical actions are taken, and reduce variability between pilots or doctors for that matter, and enhance coordination during high workload and stressful conditions. This has much in common by concept of design of the normal checklist, but the principle difference is how often you use it. And as I said, pilots are not always as good as we like to think to use the normal checklist, but they know that to use the abnormal checklist could really be an accident if you don't use it. And that's not the same with normal checklists, because most of the time it works well. And here is one example, the Hudson River, when they used checklists in order to get landing properly on the Hudson River. And that helps avoid many accidents. I can mention there was this flight landing outside in Stockholm several years ago, and several other accidents that are avoided. Well, it's an accident, but it saves lives when you follow checklists. And here is the captain who was able to do that. And it has been shown that in operating theater crisis, the largest source of variation in surgical and mortality among hospitals is that they do not manage life-threatening complications in the right way. And this is when the teams do not work well together. And for the advanced cardiac life support, if you don't follow the appropriate practices and if you don't train often, then you will lose the skills. So you have to follow the practices and you have to repeat the training frequently. Here you can also see if you have not you are not using the checklists, you do not adhere to the critical steps. So they are a tool for us. And I think we all know that in stressful situations. In my hospital, they are now trying to do those crisis checklists and put them into a computer, which is not good in my opinion, because if there is a crisis, you need to have it handy straight away. You cannot go to log on to the computer and look for the crisis checklist that you need. By then the patient is dead. You can download some of these checklist crisis manuals on the internet. There are several others, and you may even have them in Ukraine. And then, as I'm approaching the end, what Boxen, Dix Woods and companies said a long time ago is that we shouldn't think that the checklist can solve the social cultural problem. You need to have a checklist at the beginning, but you need to adapt, you have to train, you have to use it, and otherwise they are of no use. So implementation is very, very important. And what they said here is that if you think everything is okay just because you have a checklist, it's wrong. You need to use it. You need to train and train again. And then a question which has been said that before, that aviation, they need checklists and anesthesiologists hate them. Well, this is not necessarily true. And it could be the opposite. Well, we have shown that pilots do not always do what they say they do. I think it's the same for us, but this should not be an excuse that we need to have both the right number of checklists. We need to focus on training, implementation, and communication. And by that, we can improve the outcome of our patients. This is, by the way, from a flight safety meeting I attended in Jordan a long time ago, where this was on the agenda. So thank you very much. This is my hospital. I wish you all the best and good luck with your meeting otherwise. Thank you.